Hello. Hello.
Uh, Hello. Yes, Anil sir, you there?
हाँ हाँ जी हाँ जी
Okay.
Pooja, can you check right now?
1 second. No, it's not visible right now. Okay, yes. Ma'am, please try to put it in the slideshow mode.
Now you
Yeah,
see?
perfect.
Done?
Right, done, ma'am.
Thank you. एक पे बैठ जाओ. टाइम लगेगा.
All right. So, for all the speakers out there, now accidentally somebody has clicked the start meeting option. So we are already live in here, but I would request you not to touch that end event button, which is there in a yellow color. You can see. If we do that, then nobody would be able to hear us during the communication. Okay. So please be mindful, all of you. You would be seeing an end event slash over there to all these speakers.
Okay, dear.
Right. So let's wait.
Okay.
So Shirley ma'am and Shalini ma'am, you are there. We have our Med Affairs head, Dr. Atul Sharma. He has also joined in here. So you're there?
Yes, I'm here.
Okay.
Pooja,
Right.
1 minute, just 1 minute.
Great. Okay, Seema has reached in there.
Yeah, good afternoon, ma'am.
Good afternoon.
Good afternoon.
Hi.
क्यों?
So maybe I think Shalini ma'am, you can unshare the screen. It's
Okay.
yes. I think Jagdeep is also back from lunch.
Yeah.
Hi. You want to share your screen, Jagdeep, once?
Give me 1 minute.
You will send it to me.
Pooja, when I do this now also, will you able to see the screen, Pooja?
I'm able to see your screen only.
Now?
Yes. You can unshare. On the
Okay.
top, you will see one stop sharing thing from somewhere.
Yeah. No, I was checking some other option also. That's why.
Okay. Okay.
Done. ठीक है.
Okay.
Yeah.
I think only Nirmala ma'am is not there. So David, एक बार check करना please.
Sure.
Hi, Miss Pooja. I am already here.
Oh,
The
you're
board
here.
on which you can see that I am
Oh God.
only.
Oh God, you're the first person to join.
Yes, we are the first people to join the meeting. You can see from the 2:30 onwards. We are 2 o'clock. We have
Yes,
already launched.
in fact, you only started this entire.
Yes.
Okay.
So
So,
hi,
ma'am,
nice to see you, Pooja.
Same here. Can we see you, please? You're not visible.
Yes, yes, we can see you, we can hear you from the first 2:30 onwards. People are talking, na? I can see everyone.
Okay. Ma'am, can you please switch on your camera as well?
Sure.
Wow.
Hi.
Hi.
Yeah. All my team members are visible to you, na?
Yes, all of you.
Yes. Yes.
So for presentation side, your content would be presented by David, or you'll be doing it yourself, ma'am?
I'm doing myself.
Okay, perfectly fine.
Yeah.
So, ma'am,
Shall I
we
share the
can.
screen?
Yes. Let's check that also.
Sure.
Jagdeep is checking his.
Okay, first.
Share.
Okay, Jagdeep is doing that. This is boardroom coming in. So,
Slideshow कर दीजिए.
Okay, fine.
perfect. Yeah.
Perfect.
Perfect. Slides are moving, ma'am. Can you just check the second one as well?
Yeah, I have checked already.
Okay. Perfect.
I have checked all my video also. I have checked through this.
Wow. Super. Right. You can unshare, ma'am. We'll have Jagdeep also. He will share from his side as well.
Right.
I think they're moving as well. Perfect. You can unshare, Jagdeep. Thank you.
Thank you.
Let's wait then. Binu ma'am would also be joining in shortly. So we'll be starting at 3 o'clock.
Lighting.
Right. So a very good afternoon, all of you.
Good
So
afternoon, Pooja.
good afternoon, ma'am. We are all set to start our Ivy Talks February edition. This is the new Ivy Talks 2026. We just had the kickoff in the month of January on the Ivy Nurses Day, and here we are to start 2026 from the newest chapter on board, which is the one of the newest chapters on board, which is the Punjab chapter. I will just
Yeah.
right. So we have the program has got a lot of love and appreciation from all across, and the topic also is very, very, very interesting today. We are talking about innovations. We are talking about redefining IV therapy, and as we all know, we have a very strong panel today comprising of leaders from across the domain. And to start with, we have Colonel Binu Sharma ma'am, CEO INS India, for officially flagging off the session today. Over to you, ma'am.
Thank you, Pooja, and thank you, our expert panel members, and thank you, audience, for joining on a Saturday afternoon. I represent Infusion Nursing Society India, and I'm very, very proud and glad that we just completed 1 year of Ivy Talks, and we have also completed 15 years of INS India journey. That is a very, very tall order. We have multiple state chapters, and today Punjab chapter is hosting and driving the Ivy Talks. And we have doctors, we've got consultant from NICU, from Fortes, we've got Miss Shirley, CNO Max, we've got the education team from Max, Mr. Jagdeep. We have got Miss Shalini from SPS Apollo, and we also have got, I think, education team and administration team from Fortis Jalandhar and Fortis Mohali. So it's an absolute pleasure to see. It's a collaborative effort, a interprofessional collaboration coming forward to make a difference in the field of infusion therapy. And today the topic is loaded with is going to be loaded with new ideas, innovations. So, reimagining IV therapy. IV therapy is not new to any one of you. Since the time you have entered the profession of nursing, also doctors, in whatever capacity, IV, peripheral IV cannulation is one intervention you do all the time, right from the ER to the critical, non-critical area, and every single area of the hospital. It has already gone beyond hospital care, whether it is home care or patients coming for a day care. All of that involves the IV cannulation, and hence it is time for us to reimagine what could be done to make IV therapy safer, more efficient, uh, with minimal or zero complications, with highest dwelling time of the lines, with excellent infection control practice, securing it well, and complying with everything, and thinking newer methods on how to incorporate practices which make a difference to the patient. Patients definitely are looking at a better experience, enhanced experience for IV or infusion therapy, because almost every patient goes through it the moment they come to a hospital. So I am sure the panel is going to really have best practices deliberations, new ideas coming up, and all of you who are in the audience will have a great 1 hour, 1.5 hour experience listening to the new ideas. I definitely urge all of you to take forward all the learnings and create more value for infusion nursing society, and above everything create more value for your nursing practice. Thank you for Polymed for hosting it month on month, relentlessly, consistently pushing various chapter heads to really come forward and contribute to IV Talks. Over to all of you panels, over to you, Ms. Shirley, as a moderator, and everybody else as a contributor. We also have the newly elected president of INS India, Captain Madhukari Ray, is also in the call. I just noticed it. So, Madhukari, you may want to add some important messages for the group. Over to you, and thank you for having me join the program. Thank you.
Good afternoon, everyone. Good afternoon, ma'am. Thanks to you for introducing me and the entire ice-breaking session from your end, which is very, very important. Your presence makes a difference always. We are thankful for having you here in the session. And this is a new chapter. Punjab is a new chapter. So all the way they will highly be motivated by your presence and all of our initiatives that we take for INS India to improve day on day. And I especially thank the entire team of Polymate, right from Dr. Atul and Pooja and everybody for hand in hand with INS India to be together in the journey to ensure that we improve every day in the nursing practices that we do at bedside. As you rightly said, that patient comes in from the time of admission till the discharge. Infusion therapy is in the process and it needs an excellence. It needs a skill which is to be attained at any cost. So we need to be on top of things so that we can achieve actually excellence in all times that we practice. And that is the reason these initiatives really help us. So with that, it is important that I go to today's theme. Today's theme is very, very important and apt because as technology is advancing, so we should be able to adopt technology and make full use of it so that we can make excellence in that part also with the help of technology. So ultrasound guided vascular access is such a technology which has been practiced for many years outside India, but it is important for us to ensure that now in India, we make it as a daily practice for all of us by all institutes, because it gives lot of clarity in terms of, successful cannulation and vascular access. Actually, traditional method of that is a blind method of doing access by only palpation and the visualization, the vein that we visualize. But it is important for us that we ensure that whether we are navigating to a correct venous access or not. And it has been seen, it has shown, researchers have shown that this ultrasound guided vascular access has actually given us lot of improvement in terms of first peak success rate, particularly for patients who are having difficult IV cannulation. So DIVA patients actually are getting maximum benefits. And we have seen in the field of oncology, our patients are mostly having difficult cannulation. So for them, this is a great achievement. Also in emergency, which is a very, very challenging area where we have patients coming with dehydration, where patients are coming with shock. So we don't get to see the veins properly. So this ultrasound guided access is going to be a key for all of us to have a successful success rate, because this is imperative that now at the time we ensure that we avoid multiple pricks and we avoid the central venous access wherever it is not required. So device should be used appropriately as per the need and as per the number of days and the patient's condition should be placed in front before deciding that what we want to do, which device we want to put, whether we want to do peripheral line or whether we want to do central line. By all means, ultrasound is going to help us to the maximum this optimization for the cannulation that we can do by using ultrasound guides. So without much ado, I just want to hand over to the panelists. We are looking forward to see a wonderful discussion coming forward by the panelists that we are having here. All the best to all the chapter heads and everybody, those who are present today. Thanks to you for being here. Thank you.
Okay, I'll take Pooja ma'am. Good afternoon to all respected dignitaries, esteemed speakers, nursing leaders, and healthcare professionals joining us from across the various institutions. This is Shirley, the moderator of today's session. I'm working as CNO in Max Mohali. On behalf of organizing team, it gives me immense pleasure to welcome you all in this online academic session today on advancing safety, innovation, and excellence in IV therapy and vascular access. So I truly appreciate taking your time from your busy clinical schedules to be a part of this important sharing information. Moving to speaker one, I'll first expert session. IV therapy in critical ill patients requires precise expertization and proactiveness. It is my immense pleasure to introduce Ruchi, nursing educator, Fortis Hospital, Mohali, who will be speaking on IV therapy in critically ill patients, its challenges and solutions. Speaking about Ruchi, she had done her bachelor's and master's from Baba Farid University with 5 years of experience. She currently is working as a nurse educator in Fortis Hospital, Mohali. Ruchi, now the platform is yours. You can take over this.
Thank you so much, ma'am. Ma'am, is it visible to all?
Perfectly fine.
Okay. Okay. Thank you so much, ma'am, for the introduction. So, good afternoon, everyone. I'll be discussing about the IV therapy in critically ill patient, and I'll be also focusing on the challenges we face and the practical solution we can implement in clinical areas. Before I start my presentation, let me begin with the thought. In critical care, vascular access is not just a line, it is a lifeline. So every drop that goes through this line matters. It may be maintaining blood pressure, controlling infection, or supporting failing organs. So IV therapy is, not just about giving fluids or drugs, it is about protecting a life. So that is why how we manage IV therapy in critically ill patient become extremely important. So the objective of my presentations are to identify major challenges in IV therapy in critically ill patients, to understand patient-related and system-related risk factors. Also, I'll discuss about the evidence-based practical solutions and strengthen nursing responsibility in IV safety. So now let's just understand why IV therapy is lifeline in ICU. So I think we will all agree that in ICU, almost every critical patient depends on IV therapy. Because in critically ill patients, we cannot depend upon oral medications. We need a rapid reaction. Also in critically ill patient, hemodynamic can change, within a minute. So IV therapy has direct impact on patient survival. So in ICU, we can say that IV therapy is not an option. It is an essential thing. That is why IV therapy is the lifeline in ICU. So there are several patient-related factors that can compromise the safety of IV medication in critically ill patient. So these are the physiological condition. So that makes IV therapy more complex and also increases the risk of complication. So first is poor venous access in shock and edema. So when we talk about critically ill patient, so in shock, the vein become very small and it is very hard to see the veins. So if the patient has swelling, inserting and maintaining IV lines become very difficult. So second is hemodynamic instability. So in ICU patients, blood pressure can change very quickly. So we all know. So IV medication must be given very, very carefully. Third is multi-organ dysfunction. So if kidney, livers, or the vital organs is not working properly, the body cannot handle drugs and fluids. And lastly, fluid overload. So if we give too much fluid, and it can cause breathing problems, swellings. So in critically ill patients, the IV therapy needs close monitoring and a careful judgment. So now moving ahead from patient-related challenges, let us look at the system and practice-related challenges in IV therapy. So first, drug incompatibility and calculation errors. So in ICU setting, we have all seen the multiple IV medications are often running through a same line. So if compatibility is not checked properly, so it can lead to if the compatibility is not checked, so it can lead to drug effectiveness. So small calculation error in infusion rate can cause serious harms, especially in critically ill patient and pediatric patients. Next is high alert medication administration. So high alert medications like insulin, potassium, heparin, vasopressors. So a small mistake in dose or infusion rates can lead to life-threatening complications. That is why हम high risk alert medication को double check किए बिना नहीं देते हैं. So infection risks, especially clepsy. So center lines are life-saving, but they also increase the infection risk if ANTT, aseptic non-touch technique, we are not following. So proper hand hygiene and timely line review is also very, very critical. And lastly, improper line maintenance and documentation. So if we fail to document, if we fail to label the lines correctly, or not documenting insertion date, or missing daily assessment, so it can increase complication and also reduce the patient safety. So overall, if I talk about the IV therapy safety depends, not only the patient condition, but also on the strict adherence to system and nursing practices. Okay, so let's just, after discussing the challenges in IV therapy in critical care, now let's just focus on practical clinical solutions. So first is early selection of appropriate vascular access. So in critical ill patient, what happens? Choosing the right vascular access at the right time is very crucial. So for example, if patient require vasopressor or multiple inotropes, so it is nurse responsibility to should identify key which IV access is important. So instead of peripheral attempts, we should ideally have central venous access. So next is use of ultrasound guided insertion. So this reduces delays, complication, and second use of ultrasound. And the use of ultrasound guided insertion is look easy to हमको easily vein मिल जाती है मतलब. So hemodynamic monitoring during infusion. So in ICU patient with difficult vein, the ultrasound guided improves first attempt success. So in hemodynamic monitoring in critical care, so IV drug directly affect blood pressure. We all know the heart rate they affect and the organ perfusion. So continuous monitoring allows timely titration of vasopressins, fluids, and inotropes to maintain stability. Lastly, the strict fluid balance monitoring. So fluid therapy in ICU is very, very a delicate thing because both fluid overload and fluid deficit can worsen the outcome. So accurate intake and output charting and assessment of edema, it is very, very essential to ensure the optimal fluid management. So effective IV therapy in critical care is not just about administering fluid or medications. So it is about how timely decision, continuous monitoring and evidence-based practice. So it is all depends upon the continuous monitoring only. Now let's discuss the most crucial component in IV therapy in critical care is the role of nurse. So nurses plays a central role in ensuring safe and effective IV therapy. So first is accurate assessment. So before initiating IV therapy, nurse assess the vein condition. Okay. Hemodynamic status the nurse has to check, and the fluid requirement. So this ensures the appropriate vascular access and correct therapy planning. So accurate assessment is very, very important. Second is safe medication administration. So nurses are responsible for checking drug compatibility, drug dilution, infusion rate, drug calculations, and double checking high risk. So this prevents serious medication errors. Third is ANTT. So a strict aseptic technique. So by following infection control bundles, it reduces the risk of bloodstream infection. Last is documentation and continuous monitoring. Continuous monitoring. So in critical care, patient can deteriorate rapidly. So we all know कि patient अभी तक तो ठीक था और थोड़ी देर में deteriorate हो गया. So it can deteriorate rapidly. So nurse continuous monitoring vital signs, infusion rates, urine outputs, and fluid balance, is very important to detect the early complications. So last is documentation and communication. So accurate documentation of insertion date, line assessment, intake output charting, and communicating the change is very important. So nurses are not just administering IV therapy; they are active safeguarding the patient's safety, through vigilance, through clinical judgment, and evidence-based practices. So, to conclude my presentation, all I want to say is that IV therapy in critical care is not just a routine procedure, it is a life sustaining intervention. So, while technology, the protocol, and guidelines supports us, the safety and effectiveness of IV therapy ultimately depends upon nursing vigilance. Uh, in critically ill patient, even a small error in IV administration can significantly, impact the outcome. So therefore, a critical care nurse, as a critical care nurse, our, our role is not just to administer medication, but to ensure precision, to safety and continuous monitoring at every step. So safe IV therapy is responsibility, and in ICU, it can truly make a difference between deterioration and recovery. Thank you so much.
Thank you, Ruchi, for highlighting real-world challenges and practical solutions in managing IV therapy on critical ill patients. Okay, moving on to next speaker, I'll call upon Nirmala, CNO of Fortis Shriman Hospital, Jalandhar. Healthcare innovation continues to redefine clinical practice. Ultrasound guided vascular access has significantly improved success rates and reduced complication. I now invite Miss V.R. Nirmala, Chief of Nursing, Fortis Shriman Hospital, Jalandhar, to speak on ultrasound guided IV, the future of vascular access. Speaking about Miss Nirmala, currently she's serving as CNO at Fortis Shriman Jalandhar, having 30 plus years of comprehensive experience in nursing profession, including more than 15 years in nursing leadership role across some of the most hospitals in India and international. Post-graduation in psychology, PG diploma in guidance and counseling, and she has advanced diploma in quality management and Sigma. She has 6 Sigma green belt too. So, ma'am, I request you to proceed further. Nirmala, ma'am.
Hi, good afternoon, everybody.
Good afternoon. Good afternoon.
Yeah.
Before proceeding, I would, ma'am, excuse me, before proceeding, I would request everyone to mute the PCs, your computers, so that we can listen to the discussion what she want to explain about the ultrasound. And
Yeah.
thank you. Thank you.
Okay. Shall I?
Sure, ma'am, you can proceed.
Yeah. Hi, good afternoon, everybody. Myself, Nirmala Reddy, Chief Nursing Officer from Jalandhar Unit, Shriman Hospital, converted to Fortis Hospital. And today I'm speaking about the ultrasound guided IV access the future of vascular access. Thank you so much, Polymed, for giving me this great opportunity to share all these my thoughts. And now let us see the videos. Slideshow already. Yeah. So just let me give the introduction of IV guided access ultrasound guided. Peripheral IV catheter insertion remains one of the most frequent performed invasive procedure in day-to-day life in healthcare setup globally. But despite of its commonality, traditional blind methods which we are using and solely on the palpation and visualization of the veins we are doing, which is associated with the failure rate of 40% according to the studies.
Ma'am, your screen is
Ma'am,
not visible.
ma'am, your screen is not.
Just a second. Why my screen is not visible? अभी तो किया. Sure. Yeah. Is it visible now?
Yes, ma'am, we can see
Yeah,
you.
ma'am.
We can see the PPT also. Thank you.
Okay, thank you so much. So, according to the studies, the blind methods are giving the 40% of failures, and so with this patient-specific anatomical variations like deeply situated veins and blood vessels, fragile blood vessels, and history of difficulty IV access are particularly susceptible to these challenges. Vulnerable demographies like pediatric cases, oncology patients like ma'am rightly said before, and inheritably small veins in pediatrics. Obese patients, we can see the deeper veins, and also elderly patients with fragile or rolling veins commonly experience this kind of suffering. The staff inefficiency at times and the economic strain will be increased on this, represent a systemic cost. This comprehensive impact extends beyond the direct. So pre-procedure expenses to affect overall the hospital efficiency and patient flow. So whenever there is a word of mouth will spread that there is a difficulty in cannulation, extravasations, thrombophlebitis, all this will gives the patient flow this dependency. So ultrasound guidance offers a transformative solution to these long-standing issues. The early light ultrasound machines were hampered by poor image quality, but imaging quality increased from the 2010. For this reason only, studies published in the last 15 years were incorporated. So this is the brief introduction about the ultrasound guided IV access. Now, ultrasound guided IV access, the future of vascular access, why it is so. So from blind to practice to, we are going through the evidence-based precision nursing. Ultrasound guided IV access is not just a technology, it is a transformation in nursing practice for safer patient care. So this is the few glimpses of ultrasound guided IV access, how the probe should be placed on the vein so that vein and artery now can be visualized very easily and the vein can be identified easily through the needle insertion to completely procedure formation. We can see through the probe. Guide wire in the vein can be moved forward and we can fix the cannula very easily through this ultrasound guided IV access. What is the learning object from this IV ultrasound imaging? Ultrasound evolution of IV cannulation practices, analyze the research evidence supporting ultrasound guided IV, compare traditional versus ultrasound guided, techniques identify anatomy using ultrasound, apply patient safety principles, prepare for future nursing competencies. You can see the glimpses of how the cannula is moving forward through the ultrasound guided. Now, why IV access is challenging? As earlier we have discussed that The patients, depending on the patients who are coming in the shop, pediatric cases, demography like oncology patient, dialysis patients, we have so many difficult IV cannulation process which may lead to the extravasation, thrombophlebitis, infiltrations. So according to the studies, peripheral intravenous catheters complications are increasing day by day globally. So this improper, difficult, insecure access have unacceptability. Overall failure rate is, according to studies, 35 to 50% worldwide. The most common complications is infiltration or extravasation is more than 20% nowadays. With overall up to 75% of patients are experiencing some form of peripheral invasive lines IV access related issues during this therapy, hospitalization. If you see the history of IV access, when I was a staff nurse, we can see the patients who are coming to the emergency, the babies who are coming with the dehydration, the only option left was venous cut. So we were doing venous sections quite frequently, like how much we are doing the IV line insertions. So because of the early practices of blind landmark based cannulations, visual inspection only we use or palpation we are using. Sometimes while inserting the cannulas in the brachial, trial and error method we are using. Multiple needle pricks we are giving. High complication rates were there and venous sections were too high in such a days. So if you see the history of IV access old practices, now we can consider as a art rather than a science. So if you are very expert in palpating and visualization of the vein, then only you can perform the practice very well. So that was the art rather than the science. But now we are talking about the science. So because of the art and old traditional blind methods, problems with that was failure up to 40% as studies said globally, I told you. The pain and anxiety of the patient, distress of the patient will be increased too much. There are sometimes instead of vein, they are inserting the cannulas into the arteries. Too many hematoma formations and arterial punctures, delayed treatment because of the failure of IV cannulation, proper cannulation. There will be delayed in treatment. Nurses are frustrating because of the difficult IV cannulations. Multiple attempts increase infection and infiltration risk significantly. So according to this, ultrasound guided IV access shows 85 to 95% of the success and reduce 50% of the complications. So who are the difficult IV access patients? So as image shows, the patients, those who are healthy, which they have the deeper vein tissues, elderly people, those who are having the fragile veins and rolling veins, oncology patients already with the multiple pricks, it will be hardened veins, dialysis patients, patients who came with the shock, pediatric patients completely, they have the very fragile veins, dehydrated patients already sunken veins can't be seen properly. So difficult IV access patient need to 2 to 4 attempts on an average using the blind method. Now why was that change needed? As global shift, why the change is needed? Healthcare demands, nowadays we can see that patient demanding for the expert and skillful nursing services or healthcare services. So in view of that, according to the healthcare demand, patient safety, first attempt success, timely efficiency. In every corporate hospital, I can understand the nurse bed time ratio is calculating. So one nurse, how much time she is performing her services per each bed. This is what the administrators are looking for. So if the attempts are increasing, nurse frustration is increasing, the long time waits, patient treatment delays, all this will create the time consumption. So first attempt success must be needed, time efficiency must be needed, less complication, patient should go without complications. Evidence-based nursing, this is evidence-based nursing we are doing, not the blind practice. It's a cost saving. Instead of one patient is having 3 to 4 cannulas, in every setup, infection control nurses are calculating how many cannulas per month we are using on an average, how much it is coming. So where we need to improve our skill. So when the competency assessment is doing, we are checking all these things. So cost saving also very important for the patient. So all these complications, all these failures now demands needed ultrasound entering nursing practice. Now, so ultrasound views are like this in short axis and long axis. You can see the ultrasound, how the vein and artery is visible through the nursing staff. What is ultrasound guided IV access? The definition. Now we are coming to the ultrasound guided actually. So the definition is a technique using real-time ultrasound imaging to visualize the veins and guide needle insertion safely and accurately. We can say in one word, see before you puncture. So you are seeing directly and puncturing the vein. It depends on the what you are looking on the vein and which vein you are choosing for the IV access. Now, you can see one simple few seconds video here, how it is visualized. So this is guided peripheral IV access. Now, what is the scientific principle behind this? Ultrasound allows visualization of vein depth, you can see, vein diameter you can see, vein direction, whether it is going straight or curves, it is going, you can see, patency you can see, relationship to the artery and nerve we can see. So this converts blind insertion to the image guided insertion, which is a scientific principle behind this. Now, evidence from research, we can say first attempt success is up to 85 to 95% is the first attempt success globally, which we can see in the references. Complications reduced, as I told you earlier, complications reduced 50%. Time to cannulation is reduced significantly and patient satisfaction improved drastically. So this ultrasound guided IV access significantly improve the success rates in difficult IV access patients compared to the traditional methods. Now, old practice versus future practice. If you compare both of these practices, old practices we use the landmark where only the people can say vein can be seen here, vein can be seen here, or vein can be found in the lower limbs, which we discourage normally. The future practice is ultrasound guided, you can see very easily. In old practice, we had a multiple attempts, but in ultrasound guided, we can go in the first pass success. In old practice, we can see it is a very painful practical method, but in the ultrasound guided, it is a very minimal discomfort because through guidance, you are inserting the cannula and you are choosing the diameter and depth and everything. So it is very easy. The risk of injury is high in old practice because you are palpating the vein and you are inserting the cannula. But here, due to visualization, the safe visualization is there. Here, old practice, skill by guess. But in future practice, skill by science. So with this, old and future practice are having this so much of variation to the patient satisfaction. Nursing role evolution. It is earlier nursing role was task performer, but modern nurse role is clinical decision maker. Her empowerment increased to clinical decision maker. She can be a vein assessor. She is a safety advocate and technology user. So modern nursing is a science-based profession here. If the nurse is using the ultrasound guided IV access, then we can say she is a science-based profession. Now, how to identify the vein and artery? It is a simple clinical knowledge. Vein is completely compressible, where the artery is not compressible. When the vein doesn't have any pulsation, but artery does. When the vein wall is very thin, but artery wall is very thick one. If you see the shape of the vein, it is an oval shape, but artery is a round shape. Now patient preparation, as usual, how we are doing the vein cannulation preparation, the same way. Here the infection control rate also very good. So because if you cover the probe completely and use a hand hygiene and aseptic technique, it is a very easily achieve the complete aseptic techniques. So only explain the procedure. Consent must be taken because you are doing ultrasound guided, it is a cost effective. Position the arm properly, tourniquet, and then use the hand hygiene and area aseptic technique. Probe cover it, use the gel and check with the probe and patient-centered care emphasis. Now, step-by-step scientific technique is nothing different, only you are visualizing and inserting advancing the cannula. Here for the infection control and safety, as I told you, hand hygiene, sterile gel, probe cover, skin antisepsis, secure dressing and documentation. In the procedure of insertion of the cannula, scan the vein, measure the depth, align the probe, insert needle under vision, and then see the needle enter into the vein, advance the cannula and secure the dressing. Finish. Now complications reducing by ultrasound IV access is there is no arterial punctures because of ultrasound guided. No hematomas because you are inserting into the proper selection of the vein diameter, and there is no extra vasations, and multiple attempts are reduced, delay in treatment also reduced. So all these complications which are routinely we are seeing on day-to-day basis because of the blind methods, which can be reduced by the ultrasound guided IV access. So cost effective and quality improvement impact is less cannulas are wasted. As per the scientific noted, it is calculated 3 to 4 IV cannula per patient using. So now if we use the cost effectiveness according to the ultrasound guided, less cannulas are wasted, less central lines will be inserted because peripheral lines are very easily insertion through the ultrasound, shorter stay and less complications, better resource utilization. So ultrasound guided IV leads to higher patient satisfaction, reduced complaints, better audit scores, and improve the nursing key performance indicators of IV complications and phlebitis. The future of nursing practice is future trends, ultrasound in routine nursing it should be, and ultrasound assisted vein detection, portable handhold ultrasound, nurse lead vascular access teams. The training must be in the teams must be prepared. So here I am giving the key take home message on ultrasound guided IV access is from blind to vision, from guess to science, from pain to comfort, from risk to safety. So technology empowers nursing excellence. So this would be a great initiative if you implement it in our setups. So the final slide is save the vein, see the vein. Thank you so much. If there is any questions related to this, I'm happy to answer.
Is there any question to ask for Ma'am Nirmala? Anyone want to ask something? Okay, yeah, ma'am, there is a question in chat box.
Okay.
What should be used as a prop cover?
It can be used as a sterile gloves, which is a plastic cover bags we are getting now, ma'am. That can be used.
Okay. Okay. Thank you, ma'am. Thank you, Nirmala, ma'am, for valuable insights into the future of vascular access. Moving on to next speaker. Healthcare excellence is built on a strong system and collaborative models. To discuss whether specialized vascular access teams are the need of the hour, I invite Mr. Jagdeep Singh, nurse educator, Max Mohali, to speak on vascular access team. Do we need one? Talking about Jagdeep, Jagdeep has done his BSc nursing from MMU Mulana. He has vast experience in ICU critical care nursing, and he's a infection control nurse. And now at present, he is working as nurse educator in Max Mohali. Over to Jagdeep.
Madhukari ma'am wants to add something. I guess she's raised the hand, ma'am.
Okay, ma'am. Yes, ma'am. Madhukari ma'am.
I guess, okay. Jagdeep, you can continue. I think maybe we'll just.
Yeah, please continue. Jagdeep.
So good afternoon, everyone. So thank you, ma'am, for the. So good afternoon, everyone. So we are discussing about vascular access team. So in this session, we are discussing about what is the vascular access team, what is the vascular access team importance, and common vascular access complications which occur during IV cannulation, and what does the vascular access team do actually in the hospital, and the evidence supporting vascular access teams, challenges of implementing a vascular access team in a hospital, and when is a vascular access team specially needed in the hospital, key takeaway, and the last is conclusion. So first, we will talk about introduction. So as we all know, the vascular access is one of the most common invasive procedure in healthcare setup. So whenever any new admission come to the hospital, so it is mandatory to put IV cannulation, which include insertion of peripheral IV cannulation, midline catheter, PICC lines, or central venous catheter. And the complication can lead to the serious patient harm. But the question is, should the hospital have a dedicated vascular access team or not? So the vascular access team, what the team is do. So vascular access team is a specialized group of trained nurses, and sometimes it is physician. And the team is expert in assessment of vascular access team. Means they will identify the patient required IV cannulation or central line or any kind of EJV. Vascular access team also help in device selection, that needle-free connector required or we need any kind of cannula. Vascular access team also help in insertion of using ultrasound guidance. Ultrasound guidance topic already discussed with by ma'am, and maintenance of IV lines and troubleshooting, which the staff faces on routinely basis. So they will discuss about how to maintain the IV cannula, how to maintain the patency of IV cannula, and how to prevent the IV complications. And along with that, vascular access team also help in staff education, like they are providing teaching on VIP scale and few IV complications. So next, why is a vascular access team important? So earlier we are doing IV cannulation, like every staff is doing IV cannulation, but what is the requirement of vascular access team? So 70 to 90% of hospitalization patient required IV therapy, but the poor technique of IV cannulation can lead to phlebitis, thrombophlebitis, infiltration, extravasation, and catheter-related bloodstream infection like CRBSI, epilepsy, thrombosis, and it will directly impact to the patient safety. Patient will feel unsafe. They will never come to the hospital again because of IV complications, and it increase the length of hospital stay also. Increase the healthcare cost. So common vascular complications include multiple insertion attempt, because if staff is untrained, they will do multiple pricks and the patient will go in discomfort and also complain about the pain. And another complication like delayed in treatment, if staff is unable to find the appropriate vein, the treatment will be delayed. Definitely antibiotic can be delayed or IV therapy can be delayed. And another complications are like patient are at risk of infection, then vessel damage also, and it increase the patient anxiety and pain. And what is the function of vascular access team? The first important function is the early patient assessment. So vascular access team help to identify the patient and to identify the best vein for the patient. Like they will start from the suitable vein, like from at metacarpus to cephalic, basalic, and after that they go on for the further veins. Then helps in right device selection, that right line, right patient at a right time. Then again, it help in ultrasound guided insertion, monitoring the dwelling time, and early complication detection, staff training and competency validation. So vascular access team, they are providing training to the staff along with the competency check. Then after that, they are doing data collection for the quality improvement project point of view. Evidence supporting the vascular access team. What are the evidence which are supporting the vascular access team? So studies show that the VAT implementation lead to decrease insertion attempt. As we know, if there is a no vascular access team, staff will do multiple pricks, can be 3 to 4 pricks for one patient. But if there is a trained person, they will do less attempt, and therapy initiation will start timely. And second point is it decreases the lower infection rate. It reduces the complications. It reduces the hospital stay, and ultimately it increases the patient satisfaction and also cost saving for the patient. Benefits to the patients also, along with patient, nurses are also feel beneficial. So first benefits to the patient is it reduces the pain from the repeated attempt and faster treatment initiation. It lower the infection risk and it improve the overall experience. Patient feel comfortable in the hospital. And the benefits to the nurse include it reduce the workload for the nurses, and nurses have to spend less time for difficult IV cannulation, like especially in chemo patient and in critical units. Staff feel difficulty to finding the IV access. So if there is any expert team in the hospital, they will help. And it support for complex cases, and there is a standardized practice because vascular access team also provide teaching to the junior nurses, and they will follow the same standardized practice. Financial impact include, although initially investment is required because we have to make a new team, we have to train them for the vascular access, but ultimately it decreases the epilepsy treatment cost, like it reduces the infection and it reduces the complications also. It reduces the supply wastage because if we are doing IV cannulation for 3 times, 4 times, so it is a wastage of IV cannulas and other equipments. So it is better if a trained person will do IV cannulation. So one cannula is used for one patient only and shorter the length of stay. And organization such as INS, CDC and AVA, they are also recommended vascular evidence-based vascular access practices should be implemented in all the hospital. Competency validation should be done for all new staff and the older staff. They are also focusing on infection prevention protocol in the hospital where infection control rate is very high and IV complication rate is very high. So organization recommend that there should be a vascular access team and dedicated expertise in vascular access management. If the expert peoples in the hospital are doing IV cannulation, ultimately it is good for the patient along with the nursing staff. But there are few challenges of implementing a vascular access team, which include budget constraint. So budget also needed for start a vascular access team because in hospital we required IV mannequins, to train the nursing, and we prepare a team. So we require maximum staff. So if in hospital there is a already staff shortage, so it can be a challenge. Training requirement can be a challenge, and resistance to the change. Few hospital are resistance. They don't want to create any team in the hospital. So this can be a challenge. And at last is the administrative approval for vascular access team implementation. So there are few scenarios where vascular access team is specially needed. The first one is large tertiary hospital. So multi-specialty hospital with maximum numbers of critical bed required vascular access team. Oncology units, few hospital are specialized for onco patients. So they there is very difficult to uh, do IV cannulation and PICC line insertion. So in these areas, we required vascular access team. ICU setup and high central line utilization rate in the hospital where central line utilization rate is very high. And so in this scenario, we need VAP team and facility with the high infection rate already discussed, and the patient with difficult IV access. So case example, without vascular access team, there is a multiple IV attempts and delayed in initiation of IV therapy and increase patient dissatisfaction. Our target is to satisfy the patient, but if with multiple pricks, patient will never satisfied, they will dissatisfied. But if there is a vascular access team, they will do ultrasound guided attempt. Like in first attempt, patient will get IV cannula. Immediate therapy initiation will be start, and it improve the patient outcome and improve the patient satisfaction score. Key takeaway from this session is the vascular access team is a critical to the patient care. So complications are preventable. So the complication which I have already discussed, like phlebitis, infiltration, extravasation, they can be preventable if we have a dedicated vascular access team. So evidence already support the specialized vascular access team. If we have any vascular access team in our hospital, they will decrease the risk of infection. They will help the patient, and they will reduce the cost of the patient. It improves safety, efficiency, and cost effectiveness. And investing in expertise improve quality of care. So if we want quality care in our hospital, it is better to invest in expert team. So conclusion is vascular access team is not just a added services. It is a patient safety strategy, and hospital aiming for lower infection rate, better patient outcome, and cost reduction and nursing support should start making a IVA or vascular access team if they want to provide excellent care among the another hospital. And thank you so much.
Okay. Thank you, Jagdish, for sharing the perspectives and strengthening on vascular access practices. While safety remains central, caregivers' safety is equally vital, who are giving this caregivers, because safe caregivers ensure safe patients. I invite Ms. Shalini Raj, Chief of Nursing, SPS Hospital, Ludhiana, to speak on staff sharp safety, protecting the caregiver, protecting care. Speaking about Ms. Shalini Raj, she's a senior nursing leader with 19 years of experience in healthcare management and clinical administration. She holds an MBA in hospital administration and currently serving as Chief of Nursing at SPS Hospital. She's passionate about quality improvement, nursing education, and building strong, accountable healthcare teams. Her leadership focuses on operational excellence, patient safety, and strengthening nursing governance system. Over to Shalini, ma'am.
Thank you, ma'am. Thank you for the warm welcome, Shalini, ma'am. Thanks to Pooja for giving me this help for the organizing. Uh, Good afternoon to all the nursing leaders who present here. Thanks to Polymed for organizing such a beautiful event. As the earlier speaker said, Ruchi, Nirmala ma'am, and Jagdeep shared valuable points to the all the dignitaries and the nursing team who appears here. So I would like to begin as we begin today's session on the infusion therapy practices, it is most important. Safety is also very important. So I'll be sharing my screen. My screen is visible?
Yeah, ma'am.
Yeah.
Yes, yes, please.
So as we begin with, what is our most important topic is sharp safety. So as I would like to conclude, Polymed has given me one tagline: every sharp injury is preventable and every prevention protects two life. That is, one is a caregiver and the patient, because we both are the first line workers. So with this tagline, I would like to thank Polymed to give it the opportunity on, especially on the nursing safety. So as an introduction part, so as everyone know, sharp injuries is just not a one issue. It is significant occupational hazard in healthcare, where especially in all the areas where vascular access procedures are routinely performed. Despite of all the guidelines which we have, due to overflow and challenges in the practice, because of that, sharp handling requires consistent adherence to all the precautions and active participation from all members from the healthcare across clinical settings. With this, safe sharp practices begins with awareness and sustained through collective compliances. So when we think about why needle stick injuries is matters, so do you know, almost in all the areas we have most sharp injuries happens in few because recapping needles, overfilled sharp containers, lack of safety with the devices, inadequate supervision, under-reporting culture. These are all the most frequently happening areas where needle stick injuries can happen. Not only this, because of fear, time pressure, and due to normalization of their routine schedules, also needle stick injuries can happen. So when we move further, when the needle stick hand injury happens, what most of the staff do is they get panic. So as a golden rule, always you should remember one thing, that you should not panic as a first step. The first 16 minutes is a golden minute for us. So immediately rush and wash with your soap and water. Inform to immediate in charge, as per your organization protocol. You can inform to your ICN. Yeah, report to the occupational health team, and the baseline testings of all serology parameters like HIV, HbSAg, and anti-HCV should be done, and start preparations for as required, especially within 2 hours after the needle stick injury is very very important, so that this will be a golden minute for you to prevent for the next, it decides your next 6 months. So don't forget always to utilize this golden hour as a key point. So when we discuss about in which areas most affected areas in the hospital, these are all the areas where injection preparation areas, bedside medication administration, during blood sample collection, and the operation theater, emergency area, and waste handling points. So these zones are the high risk zones in all the hospital. We can detailedly check where, especially in OT, as when you handle high volume sharp instruments in the OT, and suturing, minute suturing needles and scalpel blades, rapid instrument exchanges in major procedures like neuro cases and ortho cases, the exchanges will happen in very fastly. And fatigue during long standing procedures may cause the fatigue, so that it is mishandling of instrument may cause the needle stick injury. At the same time, when you see in the emergency department, fast paced high pressure environment because of the rapid movements, unpredictable patient movements, and fatigue during long procedures, multiple IV insertions, suturing, and overcrowded. So based on this, you can analyze how many chances are there for the needle stick injuries. At the same time, in critical areas, the frequent blood sampling and multi-invasive interventions. Then since the IV critical areas, most frequent procedures happens in the intensive care units. Due to that also, there is a lot of chances of the needle stick injuries. At the same time, sample collection area, it is a frequent area, and dialysis unit where the catheterizations happened multiple times and multiple exchanges happened on the blood flow. So due to this, the needle stick injury can happen. And other area where in the injection rooms, high patient turnover, overfilled containers and repeated injections there, because in the procedure room always there will be a chances of repeated injection flow. That is the reason the staff may get the in needle stick injury. Disposable error due to rush, this is also will lead to the injury at the same time in procedure room. Main and most high risk area is waste segregation area, where our all GDA will collect in entire hospital. There might be missing in the nursing staff pockets, and some additional needles has carried in the uniforms, your laundries in the area where you have a linen management. There the segregation may take time. That is a very high risk area. We can consider that the GDS staff and other non-medical legal, medical staff also get the IV sharp injuries. So how can we prevent this sharp injuries? One is avoiding recapping, dispose immediately after use. So you should be very attentive before doing that. So use puncture proof containers at the bedsides as soon as your procedure done. So make sure when the container is 3/4 full, inform the GDS to remove the container immediately. That may help you to save your time. Use safety engineered devices always as per your hospital protocols. Always think on the advanced available devices to prevent the needle stick injury. So as we go, this safe framework from the infection control parameters, it helps to prevent the needle stick injuries. When we say talk about the safe framework, S is stands for select safer devices. Always safety engineer needles, needleless IV system. Recently the Polymed had got a beautiful locking system where it prevents the needle stick injury completely, where we can't even use after the administration. So the blunt suture needles where it is applicable, that can be more helpful. A stands for avoid recapping. Always this line should be like a repetitive session for the nursing staff. No recap, no bend, no break, so that we can avoid the needle stick injury. At the same time, F stands for fast disposable. So when sometimes what we do, because of the rapid situations in the wards, due to heavy movements and less workload in the staff side, patient nurse ratio, sometimes what they do after the injection, they just keep it in the trays only. That may lead to another additional needle stick injuries for the person who is removing it. So always make sure that once it is used, throw it appropriately. At the same time, last but not least, the educate and empower. The infection control team and the nursing education team and the leadership team, always we should ensure to educate, empower, and regular micro training and speak up culture. The speak up culture should be very aggressively implemented all over all the areas. The reason, the after needle stick injury, due to fear only, they won't report. Until they won't report, we won't be able to secure the staff. The staff safety ultimately lies with the own way. When you take your ownership, then definitely the speak up culture may come up fast. At the same time, we can implement smart and innovative ideas to prevent the sharp injuries, that is sharp safety champions. Recently in the infection control parameters, the link nurses are more very well versed with all the protocols. Giving the championship between them to address the staff concerns and educate them may help to prevent these kind of sharp injuries. At the same time, red dot system. What is red dot system? When we talk about red dot system, it is an open innovative idea in abroad and some other cultural areas where they follow. The red dot system is a visual safety cue designed to promote immediate and appropriate disposable of used sharps during infusion and vascular access. What happens in this? There will be a red sticker placed in the medication tray, IV trolleys, procedure kits, injection preparation areas, and the reversal time. So this serves as a real-time visual reminder. Like when we are doing it a medication, after that the red sticker shows us that yeah, this is a time for us to dispose the sharp so that we can prevent the sharp injuries. So at the same time, in the smart innovative ideas, we can think about the QR code reporting also. Sometimes the staff will feel that we should not report. In the QR code reporting system, what happens? The anonymous voting will happen. We will not even know who did the reporting, but only the person will be able to understand, the person who reported and the person who is visualizing the system. Only the confidentiality developed here in the QR code reporting. That is a good practices among to keep the confidentiality in case if they have a fear to report the needle stick injury. At the same time, sharp audits in all the areas. So sharp audits is very, very important from the infection control parameters where we can prevent the sharp injuries. Moving ahead, so what is the golden rule for the bin safety? As we discussed in the earlier, the biomedical segregation area is the most high risk zone for the sharp injuries. To prevent that, this golden rule should be applicable for as a visual aid card, yeah, some pocket card to the GDS staff and who handles this. Replace the can at 3/4 level. Never compress the can contents, and correct height and location. Sometimes keeping in a lower location above the head, this kind of mishandling also may cause the safety. So they never hand carry the sharp. This is the most thing where we can see in the bedside procedure. So this cannot be a reason for the needle stick injury. So to avoid that, you can keep this golden rules in a mind. So moving ahead, what is our responsibility? When we talk, always we say that the staff did not take in the initiative, staff should not take in the step to prevent herself. No, the complete liabilities stays with every individual. At the same time, as a visual safety rounds is very, very important to the leadership. What I would like to say that high risk zones demand high visibility in the leadership. When we fix the parameters of NSI, rates are less, complaints are 98%, when the zero incident for the 120 days, and that high risk zone segregations may reduce our little sick injuries, and the sharp safety to the staff may little vigilant at the areas. So mandatory compliance and audits are very important. Zero tolerance to the unsafe disposable. So initiating this kind of taglines may help to give the awareness. At the same time, after the needle stick injury, psychological safety for the staff is very, very crucial, because somewhere due to our busy schedules we miss their attention. They will be having that fear that I got needle stick injury, what will be the next moment? So always staff safety lies with everyone. So color coded puncture proof containers, these are all the parameters will always help. As a responsibility, everyone should talk about it. So recognizing of zero incidents in units, that is very important to uplift the nurses who reports frankly. So what is important in the sharp safety? Wear gloves when handling sharp. Do not forget about these steps. Never recap a needle. At the same time, when drawing a blood, placing IV line and anchor vein below the insertion site, especially when you do IM injection, pinch and inch. It means enough of skin. Sometimes what happens, you will not hold a proper skin at your level so that the needle will go directly into your skin. So always pinch and inch enough skin for the subcutaneous injections, and discarding of the needle is also very important. So moving ahead, from starting point to until the picking of up to the cans is our essential steps to in the workplaces. From step one, workplace safety training, always recurrent trainings as very important. And step two, handle needles with the care. And third point, disposing of sharp in appropriate container. Identifying the appropriate container is also very essential. Don't pass the fill line. When we talk about this, a 3/4 line we say, but most of the time we will miss it. We should make it as a mandatory to create one fill line in between so that they will not cross it. Last and the fourth step is lock and secure the container. Sometimes in a hurry schedule we miss to secure the lid, so that always we should double check it to lock the container. Same time, packaging the small containers also. Sometimes we focus more on covering the big containers, will leave the small container, but both are very important. Sometimes needle breakages happens in the container also. So and from using large volume container where it's required in the areas according to the usage of area. So final step, complete pickup from the biomedical unit. So but when we talk about everything, cultures matters more than policy. I would like to dedicate this point. Leaders responsibility to no blame culture, appreciation for reporting, maintain confidentiality, visible leadership support. These are all the main key points where we can talk about the staff safety. So I would like to deliver one message. A safe hospital is one where staff feels safe in the hospital. So, but last but not least, I would like to conclude one message. When we protect our caregivers, we protect care itself. Safety is not an extra step; it is a part of nursing excellence. So, when we create a platforms like this, everyone will know about the how important staff safety to the staff itself. Until you get an awareness about yourself, we cannot teach. So teacher can teach others. That is what very impactful in the sessions. Thank you, ma'am.
Thank you, Ms. Shalini, for highlighting the critically important aspect of healthcare safety. As we all know, technology plays a pivotal role in strengthening patient safety systems. As rightly said, safety is not expensive, it is priceless. To
Yes.
elaborate on this, I invite Dr. Sanchita Gupta, Senior Consultant and in charge Neuro ICU, Fortis Mohali, to speak on smart pumps and IV safety. Are we using them correctly? Speaking about Dr. Sanjita, she is MBBS, MD, and DNB. She's heading Neuro ICU at Fortis Mohali from 2013. She is a HA, BLS, and ACLS instructor too. So over to Dr. Sanjita.
Right. Good evening, everyone. Thank you so much for giving me this opportunity to spend time with my favorite people, that is the nurses. And I hope that this my slides can add more light to this very interesting topic that we are having, this IV rounds. Okay, so my topic is a little new one. It is about the latest innovations which we have not yet caught up to. It's about smart pumps and IV safety. Okay. Um, Okay, so my talk will, I'll be talking a little bit about the background and what a smart pump is. Why do we need to use smart pumps? What are the salient features? Where do we use them? And what are the best practices, advantages, and limitations of smart pumps? So, preventable adverse events lead to more deaths in the US, even more than road traffic accidents. And medication errors rank as the most frequent avoidable source of patient harm. The rate in the US is 6.5 per 100 admissions. And IV medication errors account for the largest proportion out of these serious adverse drug events. So we need to talk about what are smart pumps. Smart pumps are basically precision IV delivery systems with built-in safety checks. They allow us to deliver IV medications at a precise or specific rate. And these are connected to drug libraries and dose error reduction software. Here, you just need to select the medication from the approved list and input the patient's information, and the software will automatically calculate what is the appropriate drug rate infusion rate that has to be given to that patient, and it avoids too high or too low rate being given to the patient. So you can develop customized drug libraries, which can be specific to a clinical area or a specialty such as cardiac or neuro pediatrics. They have automatic Tollman lettering for lookalike medications. You have soft drug and hard drug limits, which I'll be explaining further. And you have standardized IV concentrations so that concentration-based errors in dispensing are minimized. So what are the key features, safety features of smart pumps? Like I've said, dose error reduction software. It compares data that we have fed in when we are programming the system, where the doses are there and they are compared to that which are given in the drug library. And this system issues warnings or blocks, highlights are available on the system if you are going above or below a certain dose range. And these can, as I've already said, tailor to specific clinical units such as an ICU or for pediatrics. This reduces the risk of human calculation errors. Also, these pumps can automatically generate compliance rates and other information, where how many alerts were given, did somebody override these alerts, and what are the practice trends for specific drugs, and so on and so forth. And these can therefore be used for further quality improvement. So why do we need smart pumps? Smart pumps are a patient safety initiative. Traditional pumps are based on volume. However, smart pumps are made such a way that a specific dose is delivered irrespective of the volume. Alerts are given by the combination of drug library and dose error reduction system, and it improves medication safety with inbuilt dosing safeguards. So smart medication delivery systems have potential to dramatically improve patient medication safety. So where do we use smart pumps? Ideally, they should be used for all IV medications as well as IV solutions, IV fluids, and blood products. Exceptions are OR. In the OT, obviously, based on the patient's condition, you will need to rapidly change, increase, decrease, add more drugs. So it is not recommended for OT or daycare surgery. And same as that in an immediate post-op care unit or endoscopies, where sudden changes may be there. But other than that, all patients and all IV medications, fluids, and blood products should ideally be given through a pump, through a smart pump. But however, it is recommended that at least minimum they should be used for high alert medications, and for all pumps which we are currently using through an infusion pump should be switched to a smart pump. These are additionally more useful in pediatric or neonatal infusions because here the chances of dilution errors are more. So as I talked about before, what are soft limits? Soft limits are those alerts which, if the physician or the nurse can override. Say, supposing it says that you are reaching towards the dose limit, if you or in maybe like a patient controlled analgesia, there the physician can override if patient is in severe pain. However, hard limits are limits which are set into the system. You cannot override these, and only on a consult from the pharmacist can these be and these usually indicate where the rate is unsafe or beyond the dose range which is there available in the drug library. So what are the practices? Always use the drug library and listen to the alerts by the system. And the drug library should be regularly updated. It requires that we conduct ongoing staff trainings so that the whatever updates are there in the programming, the staff is aware of that, and there is no human error component in using of smart pumps. And the audit should be done about the pump usage and how frequently overrides were done and why. And standardized concentration should be used to reduce error. So what is the advantages? Obviously, it reduces medication errors, it standardizes safe practice, it increases efficiency by introducing automation, it improves safety metrics for the patient as well. And there is another software which combines the smart pump directly to the hospital EMR. So whatever infusions are going, they are automatically incorporated into the EMR and the patient record. So what are the challenges? So because of excessive alarms, it can cause desensitization of staff, leading to alarm fatigue. There can be programming errors. There can be implementation gaps because these pumps obviously are quite expensive to install and start. So institutes may not be able to use them in all areas, or maybe only available in certain units. Despite being called smart pumps, these are not error proof. You can have errors such as wrong patient, wrong drug selection, documentation mistakes, programming and process errors can also still occur. Because of improper use of drug libraries and bypassing of alerts, there can be compliance issues as well. Library needs to be continually updated. If it is not updated, that will need like new drugs are introduced, and then the staff will have to bypass the system because that drug is not available in the library. Then if there is inadequate training, also likelihood of errors will increase. Then there is potential for technical issues such as cybersecurity, improperly done maintenance, or software updates. There are further latest advancements, like I told you, integration with an electronic health record for bidirectional medication orders. And advanced pumps are also available, which have direct wireless connectivity. So in a summary, smart pumps enhance patient safety. However, they require training and certification for usage. They need further updation of drug libraries and updation of the limits and updation as per of new drugs. But they support IV safety and enhance patient safety. So thank you for your listening.
Thank you, Dr. Sanjita, for emphasizing how technology, when used appropriately, becomes a powerful safeguard against clinical errors. Thank you, Dr. Sanjita. We will now move into open forum. Participants may kindly share their questions in the chat box or raise their virtual hand. I will facilitate. Yeah, here there is Prabha. And no, anyone else who raised? Okay, I will facilitate the discussion and direct the questions to the respective speakers. And this is very essential and collective learning objects that strengthens the clinical excellence. So you can share your questions. Anyone?
Ma'am, this is the webinar mode, so they would be only need to type in the chat box or in the Q&A.
Yeah. If there is anything, chat and all.
Yeah. There is one question which is mentioned, ma'am, here from yeah. So this question is that what should be used as a probe cover? Is it sterile or clean? Maybe it is for the ultrasound guided
Yeah.
PIV. Yes.
It was ma'am Nirmala ma'am. I think
Sanjita ma'am has, yeah.
Ma'am, Sanjita ma'am.
Yeah. As far as probe cover is concerned, so the camera cover which is being used for in the laparoscope, that same camera cover can be used on the ultrasound probe, or if you are not having, or you have that is the ideal recommendation. But as a shortcut, you could use other like glove or something to cover that, but that is not ideal and not recommended.
Okay.
But as in an emergency situation, that can be used. But because if you are using ultrasound probe just like that without any sterile cover, then you are making the line sterile. So the advantage that you are getting from using ultrasound will be lost by introducing unsterile situation.
Okay. Okay. There was one. How can we empower nurses to perform ultrasound guided vascular device insertion to enhance their clinical skill, improve patient outcomes?
Hi, ma'am.
Pooja ma'am, is this?
Shani ma'am, we're getting an echo from your side.
Yeah.
I'll read the question for the benefit of all. One second. So, how can we empower our nurses to perform ultrasound guided vascular device insertion in order to enhance their clinical skills and improve the patient outcomes?
Yes, ma'am. I will explain you. Could you hear me?
Yeah, ma'am.
Am I
Clear.
audible?
Yes, ma'am.
Yes.
Clear, crystal.
See, empowering nurses, first of all, we need to have the training programs, at least the skill-based competency check for 10 to 20 skill-based competency checks we have to do. And then we have to develop an SOP for that. So the candidate, the staff nurse will be well performing for the future. Because in the beginning, they may feel difficulty because of the probe and inserting cannula. But once if they do 10 to 20 skilled based training programs, they will be very well, they can manage this as time also consumed in that.
Okay.
Hope I answered.
Ma'am, Dr. Sanchita, is there again a specific prop recommended as a prop age-specific patients?
Yeah, so as far as ultrasound is concerned, there is a linear probe. Okay, the linear probe is used for vascular access. Okay, and as far as your previous question was regarding empowerment, empowerment has to come from upwards. It has to come from the management.
Yes.
The management has to stand behind the nurses and has to stand with the nurses. Only then we can have empowerment, and nothing in a hospital can move without a nurse. Everybody should understand that.
Yes, ma'am. Thank you, ma'am. Thank you. Thank you, ma'am. Thank you so much. So it was really an interactive conversation. Though it was a chat, but again, it was very nice. Any more queries in chat? I don't see anything.
Ma'am,
So,
some DMs are there. Can I read
uh,
them?
yes, please go ahead.
Thank you. So, ma'am, there is a question related to the trainings for nurses on smart infusion pump technologies. So, the question is basically, how often do you recommend nurses to receive the refresher trainings on infusion pump technologies?
Okay, so the recommendation is that there should be a 6-week training course, and with a compliance check to be done every 1 year. And for that recommendation also says that only nurses scoring more than 80% in this post test should be allowed for using these. That is the recommendation.
Okay. So, thank you, ma'am. Thank you again. Pooja, ma'am. Any more DMs?
Right, ma'am. There's actually 3, 4 are there. I'll just read them. I mean, in the interest of time, we've already crossed our time limit. We can also send some questions to the speakers as well. There is one more thing, which is, I think this is Jagdeep's topic. So can smaller hospitals implement a mini team model instead of a full vascular access team? So some suggestions on that. What could be the integral parts if we want to create some mini model instead of a full-fledged vascular access team?
Yes, ma'am, we can start with the mini model. With the staff, we can provide training to the staff, and hospital should have a mannequins so that they can practice. And along with OSCE examination, we can certify them as a vascular access nurse, and they can initiate at mini level in a hospital.
Right. Thank you. Thank you, Jagdeep. One last one I would present in here. I think most of the nurses, we have staff nurses also joining in, and this question has come from one of the staff nurse itself. How a nurse or how nurses in a hospital can build a no blame reporting culture for sharp injuries. I think this is with Shalini ma'am's discussion. So yeah, this is in there. Shalini ma'am?
Can you repeat the question?
Yes, the question is, how can nurses build a no blame reporting culture for sharp injuries?
See, when we talk about no blame, until they will not report, we will not even know who is reporting it. Due to this error, they will say all that, "Ki, I have done, I have not seen." So there won't be evidence-based practices here. That is the reason the QR code system may help that who reported and who is acknowledging will be a fast, easy acknowledgement for them. Confidentiality is easy, and who have gone with the prick, that is easy for them to understand. So here we will not give a chance at all that who have done, who have witnessed it. The person who got a prick can directly escalate it.
Okay, very good.
Sanchita ma'am wants to add something. Yeah, ma'am. Oh, your hand was raised, so I thought like.
No, sorry, I did not put it back down, and I had put it up earlier when you were talking about vascular access.
Okay, okay. Shali ma'am, over to you. I think I've done with the DMs. Few are there, but that will send, the team will reach out to the speakers. It will take time otherwise.
Okay, okay. Thank you so much for an interactive exchange of questions, which really help many people, many of them. There are many questions, queries again, so we can DM just text message to the speakers. So I now hand over to the Punjab chapter chair again, Daljit ma'am. Daljit ma'am, please, I give her handover to vote of thanks for from her. Daljit ma'am is, yeah, she's there.
Good evening, ma'am.
Good evening.
Thank you
Good
so
evening.
much for giving me this opportunity. So, on the behalf of INS Punjab chapter, I thanks everyone for joining this IV talk. Thank you, Kanal Binu Sharma ma'am, Madhugari Murray ma'am, for your guidance and joining this session. So, I appreciate the efforts of Ms. Shirley, Ms. Pooja, Ms. Niketana for planning this wonderful session. So, I think today's speakers, they did full justice with the topics and they have explained everything in a very effective and efficient manner. So once again, I thanks all the participants for joining this event. Thank you so much.
Once again, I thank all the Punjab chapter and Colonel Binu and Madhukari ma'am. I really thanks for your guidance. Pooja and Dr. Atul, Dr. Sanjita, Nirmala ma'am, Shalini, all Jagdeep, and anyone I left with, Ruchi. Everyone, thank you so much for participating, and all the virtual attendees who were, I think we went to 90 staff who attended it virtually. So thank you all, one and all, each one of for attending this one. Thank you so much.
Thank you, ma'am, for organizing it, and your introductions were very amazing. Thank you, Binu ma'am and Madhukari ma'am. Thank you, guys.
Thank you. Thank you so much.
Right. So we will be meeting next month with a new chapter on Ivy Talks March edition. Thank you. Thank you so much. Thank you, Shirley ma'am. Bye.
Thank you, one and all. Have a nice time. Have a nice weekend, all of you.
Thank you, ma'am. Bye-bye.
Bye.